I think in a way everybody's normal and nobody's normal. Everybody has their own constellation of personality traits, different things. Nobody is the same as another person. And so it really depends on what you think normal is. Yeah, so and some people, they develop problems, for example, depression. So then they cannot function very well because of how they are and what they feel and what they do. And we call that mental health problems or mental disorders. I would hesitate to call that normal or not normal or whatever. I just see people who have mental health problems. And I don't like to call that normal or not normal. Clinical psychology is it's the research on mental health problems and what psychologists can do about it. That's the simple translation of what clinical psychology is. It's about the question, what are mental health problems? Where do they come from? How does it work? Why do people get it? And what you can do about it? What can we develop treatments to solve that, based on psychological theories on human functioning? We still don't know what depression is. Nobody knows. We don't have a test to show that somebody is depressed or not. We have criteria from the American Psychiatric Association saying if you have this and this symptom and that symptom for at least 2 weeks, then you're depressed. But that's not based on very strong scientific evidence. It's a clinical measure. And nobody knows what it is. I mean, we know that it exists because we have people, we see patients suffering from it. But other than that, we have nothing, no objective measure. So nobody knows what it is. On the other hand, we know how to treat it. So we can use the idea of randomized trials to examine if a treatment works. And the idea of a randomized trial is that's the strongest experimental design that we have in science. We divide a group into two randomly, and then one gets a treatment and the other does not. And that means that we can causally say that if these two groups differ after treatment, that must be caused by the treatment. That's the strongest evidence you can generate in science. And that means that we don't know what depression is, but we do know how to treat it. And so that's a bit of a strange thing, but that's the reality I work with. We don't know what depression is, but we have this very strong scientific method to examine how to treat it. And there are still a lot of frustrating things because randomized trials don't tell you. They tell you if an intervention works, but they don't tell you how it works. So that means that we can examine if this treatment works for that group, and we know if you compare that treatment to that treatment that this is more, but it doesn't say, okay, how does it work? And it also doesn't say if what personal profile you need to have in order to benefit from a treatment. And so so we know a lot, but we also don't know a lot. But the challenge is to use these methods that we have to focus on all these new things that we can, all these new pieces of the puzzle that we can answer. Yeah, and that's what I like. That's what I like to focus on. Mental health is a very big field. There are thousands of people working in it, and I don't have the illusion that I can really change that. And it's only in the Netherlands that there are thousands of people working in it. If you look at across the world, there are hundreds of thousands of people working in mental health care. I don't have the illusion that I can change that. What I can change is our understanding of the scientific knowledge. And I think that knowledge can help shape the field in a way. I try to stay away from all the discussions about mental health care, and especially in the Netherlands, because my research is completely international. I don't examine things in the Netherlands. So I try to stay away from that, although I do know a lot about what you should do in mental health care. And if people ask me for advice, I do say that. And I just this week I was in the national newspaper. I said that the innovation cycle in psychotherapy research is wrong, because we keep on developing new types of therapy as if we don't have a lot of them already, while in the end we know that all these, especially for depression, we know that all these therapies have comparable effects. I don't say it's impossible that we find new, more effective therapies, but until now we haven't found them. And that means that we keep on developing new therapies. Well, when you look at the outcomes, and a lot of people don't do that, that's related to the fact that we work with, it's a bit of a technical story, but we work with continuous outcome measures. So it's not like that you have depression or you don't. We always look at depression as a continuum. So you have people very severely depressed and less severely depressed. And you score on a depression scale from you have 0 when you have no depression, or you have 50 and then you have but most people are somewhere in between. And if you want to examine the effects of an intervention, we always look at these scales. And it's then you have this normal distribution of the treatment group and the normal distribution of the control group. And then it's very difficult to say how much did you benefit from the therapy. And we did that. I won't make it more complicated, but we used all kinds of statistical tricks to estimate that. And then we pooled that across studies. And then we saw that when you look at 50% symptom reduction, so the symptom level is half of at what people had at baseline, we see that only 40% of people respond. So only 40% of people getting treatment get better in terms of 50% response. And that's not a lot. That means that most people don't get better if they get treatment. It's still better than doing nothing, but because the 40% is much larger than what people get when they don't get treatment. But it's still, the majority of them don't get better in depression. But we keep on doing all these trials to show that a new therapy works, and then you have a new therapy again and it works. And but what to do with these when a treatment does not work? So when you do a treatment and we have these 40% of people getting better, what do we do with the 60%? What's the next treatment we're going to give them? Nobody knows. So that's not examined. And so that's something by going on with this innovation cycle of new therapies all the time, we ignore the clinical reality of that most people don't get better. And we ignore the clinical reality that most people who come into treatment don't have depression alone. They also have a substance use problem. They also have a personality problem. They're also anxious. They have all these and we hardly know what to do with somebody who has depression and a personality disorder. We also know that we can treat people for a very long time, but they don't respond. Also not after 5 therapies. What to do with these people? And so what we do is we keep on developing new therapies, while the really important clinical questions are not answered. And so I think that, and I say that at lectures, and I tell that to everybody. Not everybody is happy with that, but that's the reality. In the 1970s, I started studying psychology. At that time, when you wanted to get your master, which had a different name at that time, that was 6 years. So I had to study for quite a long time. And when I didn't have a very strong motivation to study psychology. It was not a personal motivation in my background or anything. It was almost a negative choice. I didn't want to become a teacher, so I didn't want to learn a language, and I didn't want to. I was good at math and physics and chemistry, but I didn't want to work in that either. So then I had to choose what to do. And at that time, it was difficult to get into medical school. So I thought, yeah, psychology, that sounds good. But it was more a negative choice than a positive choice. I'm very happy with the choice now. And I think it fits very well with my person now. I like to do it. But at that time, I was not a very I was motivated to finish it. I was dedicated to study, and I did what was needed to be done. But it didn't start with a very strong motivation. And when I finished, it was actually a pretty tough time because there was a very severe economic crisis. So it was very difficult to get a job. And it took me almost a year to find a job. So I was unemployed for quite a long time. And in that time, I thought, okay, what can I do? I cannot find a job as a psychologist. So I started with law. So I did almost 1 year law study because, I wanted to get a job, but that wasn't possible. Yeah, I remember that I got an offer from because you had to register as unemployed, etc., etc. And I remember that there was a software company who were recruiting people, and I did a test to see if I fit these criteria, and then they wanted to have me, so I could have started there. But at that point, I thought, yeah, but do I want that? And then I thought, no, that's not what I want. And then I realized, okay, psychology is the thing I want to do. Yeah. And then afterwards, I got a job at mental health institutes where I worked for a while as a prevention specialist for 15 years in mental health care. I liked it. I like to work in care. I was very motivated, and I had the same drive that I've always had to do things and to do them right and to work hard. And so I was very motivated to do that. Yeah. And I liked it. Very different from university studies where you just read books and do exams and go to classes and all that. So that was, but I liked the dynamics of working in practice and to understand how things work in society, in the community, and what you can do as a psychologist to, from a public health perspective, change things in a society. I love that. And that has remained one of I think it's the most important thing I have. I like that during my whole career, that perspective on what you can do from a societal perspective to change things for mental health. I became an academic very late in my career. Most people get their PhD and then stay at the university. But I came to the university when I was 48. And I've caught up with most of my colleagues now with all the papers and all that. But I still feel a bit strange as an academic. Still don't feel an academic completely. So I still feel like I'm more or less an outsider, because I have a very different view on, I've always had a very different view on how to manage, for example, how to be a department head, how to mentor people, how to lead people. I mean, I see a lot of colleagues who only want to have the most excellent researchers in their team. While I think, yeah, but we need a lot of other expertise. We need people who are good at writing, but we also need people who are good at doing teaching. And we need people who are good at getting grants. And so we need a lot of different levels of expertise in all different areas. And I don't need only the excellent people in all these different things. I think a lot of people are very good in all kinds of different things, and many of them can be very useful in a department where you have to do all these things, and not just do the best research. And that kind of thing has always been, I've never understood it. I've never been able to understand how you can manage a department while not focusing on the strength of all the people who are working there. If you only do this as a step in your career, it won't work. You have to have this passion to work with data, to understand what's going on, to really dive into things, and to like that. If you do that just because you want to get this PhD, you want to get that degree, then you will fail. It's not enough. It's not enough motivation to get that done. So you really must like it. You must be willing on this, because I was in my 30s and I had small kids. And I remember that I with my youngest son, that I had to work on my PhD at my computer while my wife was gone, and my son had to sleep, so I had him on my chest. He was sleeping, and I was working on my computer. I remember that very well. So you really need this motivation to do things. I always think that, and I still think that when I work with other people, in the end you will get where you want to be. So you take the opportunities you see that fit with what you want. Nobody starts out with the things they really want, because that's not what young people can do. You have to do the work other people tell you to do. But you, in a way, you will get you can make choices on what you will do with the rest of your life. And it depends on the choices you make where in the end you will get to. When I started out as a psychologist, as an unemployed psychologist, I mean, if you would have told me that I would be a professor in clinical psychology, I would have told you that you're crazy. That I never thought that would be possible, or that it would be the thing I would really have this passion for, which I have now. That was so far away from me. So you can say it's luck that you got this grant, or you can say it's luck that you saw this intervention. But I'm completely convinced that that in the end, if that grant would not have worked out, there would have been something else. So these choices are, of course, I'm very privileged. I'm very privileged to have these opportunities, and I know very well that not everybody has these opportunities. But I do think that people have influence on the choices they make, and it will direct them in the direction they in the end want to go. Yeah, no, I'm very happy to retire in terms of not having to lead big research projects again myself. And I'm very happy that I stepped down as department head a couple of years ago, which was a lot of work. And so I'm very happy not to have responsibilities anymore in terms of funding, in terms of projects, in terms of contracts with of researchers. So that gives me more space to do the things that in the end I really like writing papers. Yeah.